Hello, my name is Dr. Rob Petrella. I'm Associate Professor at the University of Western Ontario in London, Ontario, Canada, and I'm also Medical Director for the Canadian Centre for Activity and Aging. My objectives with this presentation are to give you a better sense as to how you can gain access to articular joints, both large joints and small articular joints. I want to use anatomical models specifically to give you a better sense of how we obtain good access to these joints, allowing for greater success in injection therapy. And then really to help you understand the importance of how you approach your patients, I'm going to be using a live demonstration of a patient model, again to drive home this importance of obtaining good joint access. Finally, I'd like to highlight some very finer points in terms of my experience with Supplicin and Supplicin MD and giving you a better sense as to how to use these products in treating your patients with osteoarthritis. What I'd like to do now is move on to a model of approach that I use that'll help you and your patient have the best chance for success. I like to use anatomical models for this purpose to allow you to understand how best to access the joint space, how best to approach the patient who's ready for injection, and again to have the best chance at success. We'll start with the knee model and the knee injection because the knee is certainly the most injected joint in relationship to osteoarthritis treatment, and certainly the best evidence for Supplicin success is with the knee. I'll be using the anatomical model by having you understand the structures involved and how we will move through these structures again to allow you and your patient to have the best chance for success. So what I have here is the anatomical model of a right knee. The important structures to appreciate making up the joint space of the right knee include the lower tibial plateaus, the more proximal femoral condyles, and overlying the joint space is a patellar tendon and embedded within it the patella itself. Within the joint are the menisci and usually an underabundance of hyaluronic acid in the osteoarthritis condition. The structures are important in understanding the joint space access when we're considering injection. I prefer the medial approach, which forms a slight triangle medially, bordered by the patellar tendon and again proximally by the femoral head as well as the tibial plateau. Another approach is using a lateral aspect where again a triangle is made up, but there is a little bit more difficulty because of overlying structures of nerves as well as attachments of the menisci. So again, my preferred approach is a medial approach. There are really two approaches that are appropriate when we're considering knee injection. The first would be a 90-degree angulation of the knee like this. Certainly you can see in 90 degrees that the joint space is opened up medially between the tibial plateau and the condyle, as well as laterally. The joint space is increased as well. If we want to consider injection, and I have in my hand here a 21-gauge needle, it's about 1.5 inches long, attached to the Supplicin syringe, that we'd be able to gain access to the joint space at about 90 degrees with the knee in 90 degrees of flexion. The tissues that we'd be actually approximating would include the skin, the connective tissue, and what's really important to appreciate is accessing the joint through a popping sensation as we go through the joint capsule itself. So as we move through an anatomical model, it's important to try to get an idea of what we're going to be dealing with when we have a live demonstration of a patient model knee. My preferred approach to knee injections is actually taking the knee into extension of about 5 to 10 degrees. This way there are a number of aspects of the technical aspects of the joint injection that are perhaps preferred. The first is that the patient is recumbent, relaxed. We can also gain control of the knee through manipulating the patellar tendon. I like to put my hand onto the patellar tendon to relax the patellar tendon, which as you can see allows the patella to float. We can then manipulate the patella upward, again as you can see, opening joint space even more so. So the chance of success of gaining access through a medial approach is even greater. This is not the case with a lateral approach because the patellar tendon is somewhat driven down by the tissues, not allowing it to float as freely laterally. If we can gain approach with about 5 to 10 degrees of flexion of the knee, we can get great introduction of the needle into the joint space, again approximating that joint capsule and getting that popping sensation medially. To help you appreciate even more so the importance of how we approach the knee using the anatomical model, and the difference between the 90-degree angulation and the extension of the knee, allowing manipulation of the patella and opening of the joint space, I'd like to use another anatomical model. This model allows us to understand the importance of how we place our hands and the technical aspects of gaining joint space access. Again, the patella is quite easily manipulated, as we can see in this model. The tibial plateaus would be formed in this direction, the femoral condyles in this direction. And what I'm trying to do is relax the patient by placing my hand on the lower aspect of the quadricep. But by pressing down, I'm actually relieving the patellar tendon for the patella to float upward. So I have good control of the patient in terms of relaxing and putting my hand on their lower quadriceps, forefinger and thumb manipulating the patella and allowing me to manipulate it upward to gain access to the joint space, again, which is formed by the upper femoral condyles and the lower tibial plateau. I'm just going to move the model slightly to allow you to see the manipulation a little more clearly. So again, I have my hand, lower hand, manipulating the quadriceps, pushing down on the patellar tendon, forefinger and patella manipulating, and as you can see, I have my needle that I'll be able to approach at a 90-degree angulation into an enhanced joint space as I pull with my forefinger and push with my thumb on the patella, gaining greater access to the joint space. As I insert the needle into the joint, I'll pass again through the tissues I've described previously to the point where I feel a slight resistance. This is the joint capsule. I need to push through that joint capsule, feeling a popping sensation in my injection hand here. As I push through, I feel a pop, and then there's a more easy route of the needle into the joint space. I can confirm whether I have achieved joint space on a couple of different ways. The first would be to pull back on the caliber of the syringe to allow some joint fluid to flow into the very tip of my needle. Once I'm assured of being in that joint space, I gain greater access and control again by holding that forefinger and thumb in position, and I have both fingers on the caliber of the barrel of the syringe and my thumb on the end of the plunger. Important here is that we have a constant flow of supplicin into the joint. Because of the viscous nature of the supplicin, this will be a slightly greater than perhaps pushing corn syrup through a small syringe into a smaller needle. The greater the caliber of the needle, the easier the flow. I'm using here again a 21 gauge needle, but you could certainly use a 25 gauge needle, but understand that the degree of pressure that you'll need to create with your thumb will be greater in that circumstance. But again, try for a very clear, smooth flow as I'm demonstrating here, depressing the plunger downward to the base of the barrel, and done. When I'm assured that I've completed all of the supplicin transfer into the joint space, a very smooth withdrawal of the needle from the joint space, again maintaining that positioning of the patella and out. I have again great control. I can relax the patella slowly, pulling my hand off the quadriceps and reassuring the patient that they've had a good success in joint injection access. To help you get a greater appreciation for the importance of technique and technical aspects of injection, I'm going to use a live demonstration with a patient using the knee injection at 90 degrees of angulation. As you can see, I have the patient seated comfortably on the examining table with his knees overlying the examining table and obtaining that 90-degree angulation of the knee. So I have the patient comfortably seated on the examining table edge with the knee at 90 degrees of angulation. I'm placing my left hand on the quadriceps of his left knee to give me an idea of the amount of tension that he might have prior to the injection and giving me a little better sense of control over the knee as I attempt to inject. I can also identify the structures involved, the femoral condyles, the patella within the patellar tendon, and the tibial plateaus, giving me my triangle of access to the joint space here. Again, my approach is at a 90 degrees angulation into that joint space, and I get a sense of where I am by again using my thumb and forefinger on the patella. I gain access through the tissues previously described, nice and simple, smooth entry, until I gain access to the space. I feel a popping sensation as I go through the joint capsule, and to confirm that that's the case, I actually pull back on the syringe slightly to get a flash of joint fluid. Again, getting good control of the knee with my hand over the patella as well as the quadriceps, a very smooth delivery of supplicin into the joint as I depress the plunger, feel for resistance, and obtain my smooth supplicin entry into the joint space. When I finish the injection, I slowly withdraw the needle from the injection space, and the injection is complete. Having demonstrated for you the approach with the knee in 90 degrees angulation, I'd now like to show you my preferred approach to the knee injection. In this approach, I have the patient lying on the stretcher in a supine position, and I prefer this approach because I know that the patient is much more relaxed, is not watching the injection process, and I can really get a good sense of how relaxed that patient is as I introduce the needle and manipulate the injection itself. As you can see, I have the knee in about 5 to 10 degrees of flexion with a small roll below the knee here. I can manipulate and get a good sense of tension within the patient with my left hand on the quadriceps as I push down to release the patellar tendon to allow the patella to float. The anatomical structures again are the femoral condyles, the tibial plateau, and the patella or kneecap within the patellar tendon here. So what I'm doing to try and gain access is again pushing down on the patellar tendon here, allowing the patellar tendon to float upward, and with my thumb and forefinger of my free hand, I'm manipulating the patella to open up the joint space triangulation here, just as demonstrated with the anatomical model. The angulation of the injection itself is at 90 degrees, and what's perhaps different here is that I'm actually introducing that injection by pulling the needle towards me as opposed to pushing it away from me. I believe this gains greater control. I'm also anchoring the lever of this injection with my small finger on the base of the tibia here, which again allows for greater control and manipulation as I access the joint space. So to review, pushing down on the quadriceps, allowing the patella to float upward, manipulating thumb and forefinger to open the joint space, hand with a lever on the tibia, and introducing the needle at 90 degrees into the joint space like this. I feel a pop, I'm into the joint space. I now have a free lever to allow me to see any joint space fluid flowing backward into the caliber of the syringe, and I'm depressing with a nice even flow using, in this case, my index finger to depress on a very regular basis with smooth flow of the supplicin into the joint space. Again, getting a good sense with my other hand, the degree of tension and apprehension perhaps in the patient as I talk to him to reassure him of a successful injection. Having finished depression of the supplicin into the joint, I slowly withdraw the needle, again have great success and control, and the injection has been a success. The evidence suggests that with supplicin for use in large arthrodial joints, typical effective treatment therapy is 3 injections separated by about 7 days. Also being found to be effective at 2 mils, which is a typical syringe volume. With supplicin MD, there's been a bit of a dose-finding effect. The optimal dose that we've found is 0.7 mils, and it's delivered again 1 week apart into the small joints. The issue here is that beyond 3 injections, we continue to see some benefit. And that probably brings up, how do we measure effect? We measure effect probably most basically on the effect in the patient, subjectively what they actually describe. Some of us use other tools to help us decide whether patients have improved as well. So I find it very effective and very helpful to have patients try to score for me how well they've done. And based on that, they decide with me as to when they'd like to cease therapy. typical effect, and the evidence suggests, is that the improvement in symptom control is upwards of 6 months. Many patients, in fact, will get improvement of symptoms beyond 12 months. Sometimes in typical clinical practice, we have patients who will return between 3 and 6 months, which itself is quite remarkable because the injections are actually completed within 3 weeks. These patients are probably returning because they'd like to gain some type of a prophylactic effect or trying to prevent the symptoms from coming back at all. And maybe what we need to think about is, again, having the patients objectively as well as subjectively identify when they best would be treated. I'm quite impressed with Supplicin. We typically find adverse event rates with Supplicin in the order of 1.5 or perhaps to 1.7%. These are all very transient effects with no long-term sequelae. In fact, most times these types of symptoms are quite within the range of experience for the symptoms themselves of arthritis. That's in contrast to higher molecular weight products. Higher molecular weight products are actually showing adverse event rates of perhaps 2.5 or even up to 5%. And this has a lot to do with the preparation of the product or production of these products, but also the molecular weight itself. Typically, the patient who will benefit from Supplicin therapy, again, probably for knee injection series, would be a patient who would be in their 60s, have symptoms of arthritis, maybe not complete resolution of their symptoms to their satisfaction with traditional systemic types of therapies. And I'm talking there about anti-inflammatory therapies, occasionally even intra-articular injection with corticosteroid. So those would be the typical patient with the knee. But what's fascinating and what's really exciting about hyaluronic acid therapy in particular, and really about Supplicin and the use of Supplicin MD, is trying to treat patients who have a little bit earlier on in the continuum of disability. And those would be patients with acute injuries of athletic nature or early symptoms of arthritis. Typically, we used to see patients just before they were ready to have a joint replacement. And in fact, this is probably not the proper approach. The best approach to treating these patients is to catch them very early in their symptoms, very early in the disease course. So typically now, we want to think about patients who are in their 40s and 50s, who may be at risk for osteoarthritis symptoms, also maybe with a family history, and look at them objectively and try to see if Supplicin and Supplicin MD is right for them. There are actually several important points to consider when we look at the advantages of Supplicin and Supplicin MD. The aseptic technique that's used to produce this product is really quite remarkable. It negates the use of formaldehyde used in other products in terms of sterilization. Formaldehyde on its own will introduce an increased adverse event rate. The use of a product that's non-avian in origin also reduces the effect of allergy in the production of symptoms and adverse events. It also negates the use of terminal sterilization, and this is a very important point. Terminal sterilization is supposedly an attempt to reduce the levels of endotoxin in the product. What in fact that does, it actually degrades the molecular weight of the product that you're trying to introduce into the joint. So you actually don't inject the type of product that you think you are. And that's a major concern for clinicians. The opportunity that Supplicin and Supplicin MD actually offers the clinicians are really quite remarkable and quite novel. Supplicin MD is a very novel product on its own. The actual design of the product, the delivery of the product, makes it very easy for clinicians to consider small joints, as we've already described. It also allows us to manipulate non-traditional joints, and I'd suggest the temporal mandibular joint here. It's really a difficult joint to control systemically with therapy, and intra-articular steroid therapy is really difficult as well. So Supplicin MD would be an ideal product to consider in temporal mandibular joint dysfunction. We also can use Supplicin in other large joints of the body, including the hip, which we haven't mentioned to date. It has great efficacy in the hip as well in terms of control of symptoms. We can consider Supplicin MD further in new opportunities like facet joint disease. Again, this really requires a clinician to be very comfortable, trained in the technique as well as the tactics in trying to access this very difficult joint too.